Hi, everyone. I'm so sorry that this year for 2021 Plains to Peaks Conference, we can't be with you in person, but we still want you to get your education, and this is our shot at virtual education at its best. So there's three of us here today, but mostly it's going to be myself, Liz Dienst, and Melissa Ortiona that are going to be doing your stroke presentation. Melissa and I are both Penrose St. Francis stroke coordinators, and we're going to introduce ourselves each one at a time because we're still trying to do social distancing. So again, thank you so much for joining us today, and to Melissa.
Hi, everyone. Thanks for joining. My name is Melissa Ortiona, and I'm an RN here at Penrose St. Francis and a stroke coordinator with Liz, and we do all the stroke alerts and the quality data for Penrose St. Francis.
Hey everybody, I'm Joni Briola and I'm one of the educators here at Penrose, and I'm so sorry that we can't be there in person, but Liz has a terrific lecture set up for you guys today, so I hope you enjoy.
All right, so here we go. All right, so the things that we want to cover with you today are defining different strokes, what the chain of survival looks like, what we do with outreach for that, identifying stroke destinations, review basic neuroanatomy, compare and contrast your stroke syndromes. We really want you to understand using BFAST because it's an excellent tool for stroke recognition, both in the field and we also use it in the hospital. And this is your way to be able to report deficits when you get to the hospital. And I want you to understand how important the pre-hospital setting affects how the patient gets treatment, the whole downstream effect, the whole hospital experience. And we're going to follow one case study. So what is a stroke? So what it is a clot of some sorts or a rupture of some sorts in an artery in the brain. It is a sudden disruption, so their symptoms come on very suddenly. You will hear people say, like, I was just sitting there eating breakfast and suddenly I couldn't get the spoon up to my mouth and then I couldn't speak right. Or I was sitting at church and suddenly I got very dizzy. And both of those are examples of people that are having a stroke. The hemorrhagic strokes, again, a rupture of an artery instead of a clot occluding an artery. The types of strokes, we just kind of went over that. Ischemic and hemorrhagic, what I want you to take away from this is that both of them are medical emergencies and the clock is ticking. We want to make sure that we get them to definitive treatment as quickly as possible. If they have a hemorrhagic stroke, it's about when we get them to the hospital, we are able to do a CT, say that it is, and we can start working on getting their blood pressure controlled, which is very important for them because it helps reduce the amount of hemorrhage. And then we need to identify if they need to go for some type of burr hole or craniotomy. So they need to see a neurosurgeon very quickly. In the ischemic stroke, we need to know, are we going to give them TPA or are they a candidate for thrombectomy or both? So again, there are two basic types of ischemic strokes, one of them being embolic and the other one being thrombotic. The embolic stroke is where a clot forms somewhere else in your body. You could have a deep vein thrombosis or a pulmonary embolus. It can come from anywhere in your body and travel up through your brain circulation and then stop in a brain artery and create an occlusion. A thrombotic stroke is an area of plaque that's already built up in one of your arteries in your brain. That keeps attracting platelets, and those platelets work on top of that plaque and actually create a clot in that artery that then shuts off flow from that artery. And that's all I wanted to say on that. Transient ischemic attack. So a lot of times you guys might be called out to someone's house and they're like, man, I had this slurred speech and my arm was numb and my leg didn't feel right, but now I'm all better. We still want them to come to the hospital because we want to do like a tune-up like you do with your car. We want to make sure that if they have uncontrolled hypertension, we're treating that. If they don't have tight control of their blood sugars, that we're getting those under control. We want to figure out the causes. Could they have atrial fibrillation and they've not been diagnosed, and they're tossing little clots? And maybe when we get them to the hospital, we see evidence of a little ischemic stroke. But if we don't, they're considered a transient ischemic attack. But we want to stop a stroke from happening. And the scary thing is that 15% of these, they go on to have the full-blown ischemic stroke. So if we can prevent that, prevention is always the best course of medicine with stroke. Hemorrhagic strokes, this is only 13% of your stroke population. Your ischemic strokes are about 87% of your stroke population. So you will logically see a lot more ischemic strokes than hemorrhagics. Unfortunately, with hemorrhagic strokes, their chance of mortality is much greater. And there are two different breakdowns in your hemorrhagic strokes. One being the intracerebral hemorrhage, which you will hear us call an ICH. The other being a subarachnoid hemorrhage, you'll hear us call that an SAH. So intracerebral just means somewhere within the brain it is hemorrhaging. There's an artery or maybe a few small arteries that have ruptured and have created hemorrhage in the brain. Subarachnoid hemorrhage occurs in the subarachnoid space, and it can be caused from an aneurysm, or it can be caused by a non-aneurysm. It can also be caused by trauma. Traumatic subarachnoid hemorrhages aren't strokes. But if they had no trauma and they have a subarachnoid hemorrhage, we consider that in the stroke family. So again, this is a spontaneous rupture of an artery, causes bleeding. Bleeding in your brain is very disruptive, and you don't do well. It's a closed space. That's one problem that we have, is that we build up pressure, and that's why they might need to have like a burr hole or a craniotomy. The other thing is well, let me go on to the causes. The most common cause is high blood pressure, and high blood pressure is a silent killer. We have people who walk around with high blood pressure and they don't know until they have something bad happen, like a rupture of an artery in your brain, or they start having neurologic changes and we find out that it's hypertensive related. The other thing is amyloid angiopathy, and all that is an abnormal protein buildup, and we usually see that in the elderly. We generally don't see that on young patients, but we can see that very well from a CTA. Those people that have that abnormal protein, we generally don't give TPA to because they have risk of microhemorrhages in the brain. And then drug abuse. So our methamphetamines and cocaine are the most common because they speed up our metabolism, they keep our blood pressure much higher and our heart rate much higher, and that creates pressure on those arterial vessels in our brain. And those arteries are much more tender. They're not as strong as like the arteries in our heart, but they also have heart attacks because of that as well. All right, so again, I talked about that you can have an aneurysm that causes your subarachnoid hemorrhage, or you can have a non-aneurysmal that is non-traumatic that causes your hemorrhage. The biggest risk factors for this, again, are high blood pressure, hypertension, and tobacco use. And cocaine is the most common of the drugs, but methamphetamine is right there with it anymore. These are the patients that often present with that sudden onset of a thunderclap headache. It's the worst headache they've had of their life. And this is the ICH, the intracerebral hemorrhage, is painful, but everyone describes this as out of proportion type of pain that these patients feel. These are the symptoms that are suggestive of a hemorrhage. Both your subarachnoid and your intracerebral hemorrhages will have headaches, generally speaking, and most of the time it's a very sudden onset to that headache. Nausea and vomiting, and when you start to have decreased levels of consciousness, this should also make you very concerned about a hemorrhagic stroke, because only our really big ischemic strokes will they have a change in their level of consciousness. Subarachnoid patients, they're intolerant to light. They'll have that photophobia. You may think that they've got a migraine headache. They might even have a history of a migraine headache. But if, again, with a super sudden onset, we still want to think stroke and not migraine. Migraines usually come on a little bit slower. They also have neck stiffness. You'll hear us or the physicians say, call it nuchal rigidity. And what that means is they have a hard time bending their neck down to their chest or bring their head back. Both ways hurts their neck. Intracerebral hemorrhages, this is why we need a CAT scan, because it's hard to tell them apart from the ischemic strokes, because they can have the focal signs just like hemiparesis, even slurred speech, aphasias, that type of thing. So that's where non-contrast CT really helps us. So stroke impact, why do we care about this? Because 4.4 million people worldwide have strokes. And 800,000 of those strokes happen in the US every year. Strokes used to be the third leading cause of death. Now we've reduced it to the fifth leading cause with our great use of TPA administration. Unfortunately, it's still the main leading cause for long-term disability. And we spend about $75 billion in taking care of those disabled individuals from stroke. So again, stroke prevention is key. And if they have a stroke and we can't do prevention, then treating them quickly is also very important. Chain of survival. This is what we're training our public all the time. Don't drive your family member in if they're having a stroke. We want you to call 911 because there's things that our EMS providers can do. If their sugar is low, you can give them sugar. And maybe their stroke symptoms actually clear up. Maybe they don't. They may still have hypoglycemia problems and have stroke. So that's why we want you to assess that. The other thing is hypoxia. There are two things that feed the brain, and if you remember nothing else from this presentation, it's that the brain heavily needs oxygen and glucose. And if it runs short on either one of those, the damage to brain tissue is far more significant and far faster. So early EMS response brings us to a quick assessment, a quick transport, and it allows for early intervention at our hospitals. So EMS transport. Most of you from Plains to Peaks area, you're in a rural community. And so in the cities, we have different levels of stroke centers at times. And depending upon their presentation may depend upon where they go. For our rural EMS providers, where you're going to go is to your access hospitals. You're always going to follow your EMS protocol, and you're going to go to your stroke ready center, which means that they'll be able to give thrombolytic treatment, which will either be TPA or tenecteplase. And then they're going to work on shipping them out, which you may be doing. You may be on the second leg of that, taking them to a final destination where they can be cared for. Maybe they'll need thrombectomy, but at a minimum, they're going to need physical therapy for an amount of time to help get them better. There's a lot of key EMS information, and you're going to hear Melissa and I hit on this several times through this presentation. And that is, please learn what the last known normal is and write that down. It may change. We may find out more information when we get them to the hospital. Like they talked to a family member and they were fine on the phone and answering things appropriately, but that is very valuable information. The other is obtain contact information. Almost everyone has cell phones now. If the family member or friend that witnessed this or was with them and called you isn't physically coming in the ambulance, we want you to get contact information so that the physician and the nurse at the hospital can contact them with questions that they may have that may make them a candidate to get TPA or not. And then early notification, when you're calling ahead and you're getting your stroke team ready, they're getting stuff in place to be able to quickly take care of that patient and quickly get a CT and then quickly give them the treatment that they're capable of doing, such as TPA. So follow your stroke protocol. Another thing that's really important is elevating the head of the patient by 30 degrees and keeping them in a midline position. This helps with pressure in the brain. And we never know where they are or what type of stroke they are. So this is a good standard of care for all your neurologic patients, unless they're trauma. A 12-lead EKG or cardiac monitoring if you have that capability, blood draw if you have that capability, starting lines. And then at the hospital, how we're going to pick up is we're going to do a CTA. And on many of our strokes, we're doing CT. We're going to do a non-contrast CT and then CT angiograms, which gives us a look into their vessels, their vasculature, large anyway, that start from their neck and move up into their brain. Sometimes this is very helpful with learning that they have a large vessel occlusion. And then CT perfusion tells us where we are in the evolution of that stroke. Not 100% of the time, but many times it does. And then MRI is our gold standard. Generally speaking, that's not our first priority to get that MRI because there's a lot of things that you have to do and many places don't have MRI capability. So CT is how we start to treat our strokes. And then these are the other things that we're looking at: labs, blood pressures. Can we give them TPA? Can we not? And then do we need to transfer them? So again, following your local protocol, if you're in a rural location, you're going to go to your access hospital that's going to be your stroke ready, and then they're going to be shipped on to either a primary stroke care center if they don't need thrombectomy care or coiling or clipping, any kind of endovascular procedure, then them going to a primary stroke care is just fine. They will be able to do all the rehabilitation work. The next level is thrombectomy capable and then comprehensive. And most of the time your thrombectomy and comprehensive, they're pretty similar in all the things that they can do. Again, follow your local protocol. All right, now I'm going to hand this over to Melissa and she's going to talk to you about stroke anatomy.
Hi everyone, my name is Melissa. You met me earlier, and I get the privilege of going through stroke anatomy. It is a little dry at times, so hang in there with me and we'll just learn a little bit at a time. So this is a great slide. It's going to show you the two arteries that feed the brain, and I'm trying to use my pointer. Hopefully you can see it. You have your carotid arteries here that go up, and then also your vertebral artery. And these are your two main feeders. These are your two main feeders into your brain. When you get into the brain itself, those will split off into your anterior and your posterior circulation. So again, here is your, sorry, I'm playing with my cursor. Here is your arteries, your carotid, and then your vertebral, and they'll go up into your brain. And then here, these are where your carotids come into your brain, and they branch off into these cerebral arteries. Your vertebrals come up here, and then they branch off as well. So what we're really mainly looking at here is when your carotids come in, they actually go into the circle of Willis. And if you kind of look at this and think of an alien, this is your easiest way to think about it. Oh, there's my cursor again. Here's his head. His antennas are here. Then he has arms, a body, and legs. So if you think of your carotids coming up through here, through your circle of Willis, your biggest artery coming off is your middle cerebral artery, your MCA is what we call it. And this is where you're going to see a lot of the patients getting thrombectomy, because this is a very common area my cursor, my common area for it to go through because it's the path of least resistance. So this also branches off into M1s, M2s, and M3s, but this is your MCA. Then if you have an ACA, which is your anterior carotid artery, not carotid, cerebral artery, ACAs, they go up and then it's like the mohawk, go up top of the brain. So they come up and then they go on top of the brain there. Then that's all, so if you cut his head off right there, that is your anterior circulation of your brain. And anything below that little cutoff is your posterior circulation of your brain. And we'll talk about BFAST and the signs and symptoms of the anterior and the posterior because they do present differently. And your posterior, you do have your PCAs and your basilar artery there. And we will talk about those, but I just wanted to know we call these PCAs. So we have MCAs, ACAs, and PCAs. So that's really the big thing in your carotids and your vertebrals. Now let me get back to my other one. So you have two hemispheres, your right and left hemisphere of your brain. And on your left hemisphere, it controls the right side of your body. Your right hemisphere controls the left side of your body. So those are the biggest things you want to remember. So if someone's having left-sided weakness, it's in the right side of the brain that typically your stroke is going to be in. So we can only make it more confusing for you, but just remember, right side is the left part of your brain. Left-sided weakness would be the right side of the brain. So just kind of thinking it that way. Just like the heart, the brain has 4 lobes. So you can think of the frontal lobe, parietal lobe, temporal lobe, and a septal lobe, and you can kind of see them in the colors there on the brain. In the next few slides, we'll go through the function of all those lobes as well. And of course, in the layers, you have your gray and white matter. Gray matter is that outermost level layer, and your white matter is that inner layer, is the communicators. So let's go to the frontal part of the brain. The frontal part of the brain is very sophisticated. It does a lot of things. You think of your primates and stuff like that, they don't have a large frontal lobe like humans do. So we're very sophisticated in that way, but it does all your motor functions and it helps you make decisions. So this is where your decisions are made. You got to think when you talk about people who have frontal lobe, they're probably the ones trying to grab at stuff and you tell them to stop it and they're still going to do it because they just can't process that executive functioning very well. So you'll have those and they kind of act differently. Also in the frontal lobe, we do have a speech function, and that speech function is called Broca's area. And it's really hard to remember all these names. So if you think of Broca's aphasia, think about broken speech. These are the people who have expressive aphasia. They're unable to think or speak clearly to you. They can comprehend, but they can't speak back to you. And they may only say like one word to you. So you don't want to say the yes, no questions because they might be able to say yes, no, but they won't be able to really carry on a conversation with you. Parietal lobe. This is where you're going to see neglect, where they're not looking on one side or they only can see half the room or things like that because they won't be able to focus on that side. They won't even know that they have a left arm. You know, you will show it, their arm and they'll think it's your arm. So they'll neglect, they won't have that side. They also have sensory deficits because the sensory strip lives here. So I'm going to try to get my cursor back up here. In the frontal lobe, you had the motor strip in there, and then right in the parietal lobe, you have the sensory strip. So you'll have more sensory deficits. You'll have unable to sense pain, temperature, or touch. We'll go through assessments to kind of show you how you can look at some of those so that you know, understand. And they won't have spatial awareness, that proprioceptions. They won't know what's things around them. The parietal lobe is very good at when you're reaching into your pocket, you know where your keys are, you can feel them, you know where they are. With a parietal lobe injury, they may not be able to recognize those things. Temporal lobe, also at the bottom here is the green. And Just like in the frontal lobe, we had a speech area, we also have a speech area in the temporal lobe, and that's called Wernicke's area. And if they have Wernicke's aphasia, they have the receptive aphasia. So they will talk and talk and talk and talk, but they won't make any sense to you. You show them the a pencil, and they'll say the cat's on the tin roof. You know, it doesn't make sense. They can get words out. It just doesn't make a lot of sense. So they also have naming issues and memory loss. So those are the biggest things in the temporal area. And then we'll go to the last lobe, and that's the occipital lobe. I think this is probably the easiest one to remember. Occipital means vision, and they have vision field cuts. So those are pretty much your 4 lobes. We're not going to go into a huge depth because we don't want to bore you to death, but those are good things to know, because if you at least know those really high level thinkings, it's easy to help identify those strokes and where they are. The other part of the brain we want to talk about is the cerebellum. The cerebellum is a very fun piece of the brain here, and it's got its right and left hemispheres as well, this right and left, when you see it. But here is where we get into trouble, because we don't recognize these strokes as well, because some of the symptoms they have can be mimicking a lot of other things. People think they're drunk, or their sugars are low, or they're having something weird going on. But if you look at the symptoms, there's loss of balance and coordination. They have limb ataxia, so they can't touch their nose and a finger. They have problems walking. They have really large gaits. Some people think they're drunk, walking around, looking intoxicated. Sometimes they don't have the limb ataxia, and they just have that truncal ataxia where they can't really stand up, or they're moving to only to one side, and they can't control their upper body. This one also, in the back of the brain, it can cause some nausea, vomiting, and headaches. Kind of sounds like what Liz was describing in the hemorrhagic stroke, but they have other symptoms as well. But we always are looking at this. These are the patients that come in dizzy, or they have vertigo. And we see a lot of dizzy patients, but we do have to tweeze these out to find out which ones are having strokes. So if you have these, don't always assume, oh, it's just vertigo or it's just dizziness. These patients do have strokes, and they present just with dizziness at times. So these little guys are always fun to look at, just because it's a quick little reference instead of all the words. Like I said, they have the truncal or gait ataxia, imbalances with that wide-based gait. And they also have the ataxia, it's just the discoordination. So the temporal side, again, is coordination for these. Keep going further down into the brain. We're going into the very primitive part of the brain, and that's the brain stem. When you have a stroke here, it's very devastating. This is where all your controls are living, your respiratory, your gag reflex, those kind of things. Things that just keep you alive. Luckily, we don't see a lot of brainstem strokes, because when they do have them, they don't survive very well, just because they can't keep their respiratory rates, they can't keep their heart rate up. They have the pinpoint pupils, they'll have arrhythmias, they will have gaze preferences and double vision, pupil changes, and discontinuous gaze. So the biggest thing is you'll see one eyeball going one way, one going straight, or one, you know, like you won't see them moving. They'll be very different than when you see other eyeball issues. They can always present with imbalance and things like that, but if you see them, you're going to see weakness on one side of the body, and the face will be having problems on the other side. So like I said, right strokes, left side. This time you're going to see left-sided issues, but the right side of the face. So it's that cross symptoms, and it's going to be very different than what you see. Again, the pictures are worth 1,000 words here, and you can kind of see what we were talking about in the nausea, vomiting, hiccups. I have seen those in patients, and you know that's a very primitive function that hiccups will occur. They won't breathe right. They won't have any chest trauma or anything like this, but they'll have some really weird breathing. They will have vertigo. They'll have those eye movements that we talked about with the deviation, the gaze, And there's the other picture on the right-hand side about the cross signs of the whole body, or left side, right side, or right side, left side, face and body is different. So how can stroke present in different locations? We just talked about that. Symptoms and exam findings depend on which area of the brain is involved. And that's why I said we would love to go more into depth on stroke anatomy, but just knowing these very primitive things, you can help identify the areas. Again, I keep saying it, left side controls the right side of the body. So just remember it's the opposite there. Cerebellar strokes are a lack of coordination and that dizziness that we were talking about. And the brain stem strokes are very devastating and they are mostly life-threatening. Early imaging leads to early diagnosis. We'll go through this real quick. And Liz is in the background, so speak up when you need to, Liz. We like to teach together, and it's really hard for us to be sitting apart there right now. So just here's the imaging with the CT scan. This is when you bring that patient in. We're in stroke situations and neurological deficits. We're going straight to CT scan. And a lot of places are going to, we're not even stopping in the room. We're going straight to that CT scanner just because this is such a valuable test for us. It doesn't give us a lot of information, but it helps us make a diagnosis to exclude things. So not a CT scan, we're going to see blood in the brain. That's going to be, I don't know, I want to say obvious, but this is something that we can see in a CT scan. We'll see if it's a tumor, a subdural hematoma caused by trauma, or non-trauma, exactly. Spontaneous, those occur as well. And then large infarcts. So if a patient had a stroke a while ago and they called you late in the presentation, we'll be able to see that on CT scan, but that won't occur until 6-8 hours, up to 24 hours on a CT scan. So that's why we can't use CT scans. So we always try to educate our patients. We're going to CT scans to look for bleeding or things like that. We're not looking for stroke.
And again, non-contrast CT is what we start with. Once we do the non-contrast CT, we can give TPA from that point if we have excluded those items on this slide.
Absolutely. And that's why it's very important for us to have people in there and be ready to go. Then we move on to CTA. So from there, we have to have that IV for that CTA. We give them contrast through an IV and then we send them back through the scanner. This kind of gives us a little bit more definitive diagnosis. We can see vessels at this time. We can see an aneurysm at this time. Some things they are still hiding at this point, but this is because we're shooting them up with dye. We get a little bit better imaging. The really white portions of the CTA is not blood. These are bones, and so we always look at the bone first to kind of get a reference of that's bone. You can see in the carotids here, also calcification will come up really white. And then you can see this is almost the color of the blood. And because that is the blood in the carotids itself. So calcification, bone, and blood, just to kind of get what colors they are. Then when we shoot the dye up, we were talking about the circle of Willis here, right? There's the head, here's the antennas, here's the arms. Well, this arm is missing a lot of information right here. It's not connecting. So you can see this flows, and then this stops here. What's going to stop that is blood clot. And we get this from the CTA. So,
and this would be a large vessel occlusion.
Absolutely. We're calling our IR docs and saying, come on in. If it's within the window of 4.5 hours, we can give them TPA and then go to IR. If they're outside that 4.5 hour window, we can just take them straight over to our IR docs and have them open that vessel.
And again, our IR docs are interventionalists and they're doing thrombectomy for these patients.
Yep. So this is really cool. So this is, remember, in CT world, your left is your right is your left. So we're looking at a right MCA occlusion. That's pretty cool. And those are great because I can see those on CT.
Oh, and now you get the arrows.
Oh, there's arrows.
Yes.
I love it. There we are. And you know what? The good news is radiologists will sometimes put arrows for you to see as well.
That's just showing you the calcification in the internal carotid arteries.
And I think, there we go. Liz mentioned that we have CT, CTA, and then the newest thing that has come up in the last few years is called CT perfusion, or we can call it brain perfusion. You'll see different slang words for this. But what we're looking for is, again, we shoot dye in, so it's a separate dye load, or is dye.
It's contrast.
Contrast, thank you. CT people hate when you call it dye. So they say you dye your
We
hair.
don't kill people.
Yeah, or we don't dye hair here.
Right.
So, so you'll see they'll shoot this in. It's just a CT when it's going across the screen. I did the mistake and was like, oh, let me see all these pretty colors because it comes up pretty colors. It's a CT scan. They run it through software, and the software then adds these colors so that we can see. And we're looking for flow and the volume in there. What we want, and it's always been confusing, is we want a mismatch in there. We want the dead tissue to be less than the salvable tissue, the good penumbra. So we'll see that. Let me get to this slide because I really like this slide. This is my favorite slide in CTs. I call it red is dead, but it's really fuchsia pink. The fuchsia pink is the dead tissue. And then if you look on the other side, it's the same part of the brain, but now it's dyed green. And that shows you all the tissue that if we get in, it's salvageable. We can get to it. We can save it if we can get that clot out. So here you can see little part of the dead tissue. Back to my arrow here. Dead and all still living. So this would be all the living tissue in that area. So we want to get this patient in there because they have a mismatch.
And that mismatch shows in the cerebral blood flow, that's the volume of 7.1.
Yep.
And then the perfusion, the Tmax, which is showing us our salvageable ischemic tissue, we call that penumbra, is 122.7, which gives us a mismatch volume of 115. That tells us that we have a lot of brain to save.
Yep. And we're ready to go at that point, hopefully. And if you're at a place and they can do these, so like there's a lot of hospitals, even if they don't have thrombectomy, they have this advanced imaging. So you might be getting that imaging and still loading them up to get them to a thrombectomy capable center. So just know that your job's not done yet, maybe. And then, of course, MRI is our gold standard. We would love to ship everyone and get MRIs as soon as they come in the door, but there are so many exclusions for MRI. If you have a pacemaker, if you have shrapnel in your body, if you have something, a knee replacement, I mean, these are some of the things that won't allow us to get a MRI. And then these things can take an hour or two to get. So we don't want to be wasting tissue at that point. So that's why we go with CT. But we always get an MRI just to make sure, did they have a stroke? Didn't have a stroke. So unlike CTs in your MRI, your dead tissue is white. This is not blood. This is your dead tissue at this point. Blood in MRI will come up black. And again, you've got the mismatch. Your left is your right image and your right is your left image.
So this is a large left MCA stroke, and you can see how much territory that covers in that hemisphere. That's a lot of dead tissue.
Yeah. So those are the anatomy and the imaging, and Liz is going to go talk about early diagnoses and interventions.
Well, and Melissa may chime in here as well, because as she says, we generally do a lot of teaching and training together. So door to needle, D2N is what it's, how we abbreviate it, is all about giving thrombolytic medications quickly. So door to needle really stands for how fast from the door did we give the medicine. And of the thrombolytic therapies in the United States, the two that are most commonly used are alteplase, which we well know as TPA, and tenecteplase, which is TNCase. The reason why we try to get away from saying TPA and TNCase is because they sound similar, but the dosages of those medications are very different, and we never want them to be confused. They are related to one another, but these are the two thrombolytics that you're going to see used maybe at your stroke-ready facility. So the considerations are about time frame. Eventually, we're going to move into brain tissue instead of a time frame, and that's where CT perfusion really helps with that. As we get better with our technology, we will find more ways to be able to treat strokes. And we're already improving leaps and bounds today from 5 years ago. So this is why last known well and normal is still so important, because we have a 4.5-hour window in order to give TPA. Now you will see some locations using extended window, which means we're going to give TPA outside of that 4.5-hour window, but there's special criteria involved in making those decisions. And it's really a small number of stroke patients that are going to be candidates to get that. But you know what? If that's 3 people a year we save from disability, that's a fantastic thing, and it's worth every minute of our time. Again, a non-contrast CT is all you need to give TPA. We will often stop at that point and start giving our thrombolytics. Medications that can interfere with getting these thrombolytics would be warfarin or Coumadin, and then the DOACs, which are their anticoagulation. They're like the newest generations, the Eliquis, Pradaxa, Xarelto, Savaysa. Those, if they have had those, we have special testing or special questioning that we need to do to see if they are eligible to get TPA. With Coumadin, we look at their INR, and if their INR is less than 1.7, then we can give them the thrombolytic medication because they're considered subtherapeutic on their anticoagulant. With the DOACs, if they haven't had them in 48 hours, they're a candidate as well to get TPA. And when we see people off of their DOACs or their anticoagulants, they're often getting ready to have a procedure. And so it's like, well, I haven't taken it in 3 days because I'm getting a knee replacement. And then unfortunately, some of them have a stroke. So getting a good history is paramount in this situation. Antiplatelet medication. I often hear, well, the patient can't get TPA because they're on Plavix. So those are antiplatelets, and antiplatelets are not anticoagulants. These do not preclude you from getting thrombolytic therapy. And those would be aspirin, Plavix, Agrinox, Brilinta, and Effient. We do check a platelet level, and that might be the only reason that we don't give a thrombolytic is because if they have a really low platelet level, we're worried about them with an increased chance of bleeding. Stroke recognition. So this brings us to our BFAST tool. And I'm going to explain this first of all, and then Melissa and I are going to go into an assessment. So Melissa talked about that we have posterior circulation strokes and anterior circulation strokes. We used to just do FAST, and FAST looks at all of our anterior circulation strokes. The BE looks at our posterior circulation strokes. So one of the things that you can do, and why we want you to use this tool, is if they have any one of these problems, they have a balance issue, or they have issues with their eyes or their face, any one of these can be indicative of a stroke, and it's fast and easy for you to be able to evaluate them. Keep in mind, this is the world of all of a sudden, I started having problems with dizziness. All of a sudden, I had vision cuts. I can't see on my left side. So this is all about sudden problems. With the face, What we're looking for is asymmetry. And with the arms, we're also looking at legs. So it was hard to fit legs in there. So just when you see arms, think of your appendages and think of arms and legs. So when we see weakness or they have sensory deficits, when we're touching them, they can't feel something. And then with speech, what we're looking at is their speech slurred? Can they get words out? When they're talking to us fluently, is it not making sense to the questions that we asked? And you can do things like simple recognition, like name this object and you show them a water bottle or a pen or a watch. Those are all items that all of us should know. And then time, for our public, time stands for time to call 911. But for us as EMS providers, I also want you to think about a thunderclap headache that came on all of a sudden, because that's sometimes what our hemorrhagic strokes do. So now what we're going to do is Melissa and I are going to do a little assessment with BFAST, and we're going to do it with the help of Joni Briola. So with this, when we have a patient that we want to check balance for, because let's say they're complaining about dizziness, we want to see if Melissa is okay to stand up. And if she is okay to stand up, then we're going to make sure that we protect her so that she doesn't fall in case she is having a stroke, or even if she just has vertigo, you can fall and hurt yourself. And then we're going to have her walk forward and evaluate her gait. So right now she's having a hard time and she's got a wide gait. And so that would tell us that there is a balance problem. And then we would go ahead and have her sit back down. And we would help her to the chair. This time we pull the chair up. But for this purpose, we're going to make her sit down. So, and then for eyes, what we would want to do is say, you know, Melissa, I just want you to follow my finger just with your eyes. And what we're looking for is we want to see that she tracks our finger on both sides. If one eye doesn't track, it's telling us about a deviation. Remember that when you have an eye deviation, it's always pointing to the problem. So if her eye deviation is to the right, it means she's having a right-sided stroke. Then with that right-sided stroke, she would have problems with the left side of her body. But the eyes will always point to the problem. That's always a good thing to keep in mind. The other thing is if you're noticing that Melissa, when you're walking to one side of her body, she's not turning with you, she's not paying attention to you, I want you to use threat. And if you do not see that her eyelashes and her eyelids are blinking to that threat from side to side, and it'll be one side only, then that's telling us that she has a neglect problem. She is not, maybe she's got a visual field cut, and maybe she's got other neglect problems. Remember, Melissa talked about you don't even recognize your own arm. We'll pull their arm in and they're like, that's not my arm, that's not my watch. So that's that neglect portion. That's one way that you can do that with eyes. So balance and eyes, again, is hitting your posterior circulation strokes. Now eyes can be both. They can be anterior as well. But face, the fast part of BFAST catches our anterior circulation strokes really well. So with face, we would have Melissa go ahead and pull down her mask in our COVID times. Hopefully that will change someday. And we would look for asymmetry on her face. What you really want to look at is at the labial folds that go from below your nose and down to your mouth. Family is really helpful, or friends, because they also can detect a slight droop much better than we can. Sometimes we think someone is a droop, and then the family's like, no, 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 that's normal. The other thing we want to do is have Melissa smile really big and show me all your teeth. And then we want to look that when she smiles or when she talks to us, do we notice asymmetry on her face? The next thing you can do is have Melissa stick out her tongue and then move it from side to side. If she can only move it to one side, again, that is a weakness that we're looking for in that face. That's something you'd want to report. And then lastly, we would be touching Melissa, and you can have her close her eyes. And which side of your face am I touching? And she can tell you left or right. Okay, so that covers our face. Arms, remember, arms is arms and legs. And one of the things that you can do is bring the arms up, and you're going to look for a drift. The other thing that you can do is push down, push as hard as you can. Try and keep your arm up. Don't let me push you up. Either way, however you want to do that, that is part of a neurologic exam, but it will also tell you weakness in one limb or the other. So again, droop or weakness. You can also do grip strength, but remember that grip strength can be separate from arm weakness. All of those are reportable neurologic problems. The next thing you would do is if she were laying down on a gurney or even in a chair, you can bring her leg up and ask her to hold it up for you. And if she can't hold that leg up, again, it's showing you the side of the weakness. The next thing that you can do with the arms and legs is sensory. You can do from left to right. And this is another cool little trick of evaluating neglect in your BFAST, is you have the patient close their eyes and you touch them on both sides. And if they can only detect it on one side, it's telling you about neglect. So if she couldn't feel it on the left side, but she felt it on the right side when I'm brushing both arms, that tells me that she has some left-sided neglect. You do the same thing with the legs. Now with speech, you're going to ask her questions, and you're going to evaluate her for her ability to make speech, her ability to follow commands and answer questions correctly. And you're also going to see if she has problems formulating words. So Melissa, can you tell me what month it is?
July.
Okay, so it's important here that you know what month it is. And right now it's February. So that's a little concerning to me that she just told me that it was July. That is indicative of an expressive aphasia. She got the words out just fine, but they're not correct, right? This isn't July. So then if she had some slurred speech problems, she may sound like she's intoxicated. And you can have that even like mixed. Sometimes you get some eye problems. You're not sure if it's posterior or anterior. And then they have the slurred speech. So again, when you're talking and you're asking questions, can you identify this object for me? And use simple objects that everyone would be able to identify.
It's something you put on paper.
Okay, so she's having problems there again, and that's still showing me an expressive aphasia. She kind of can describe it, but she can't say, that's a pen. She should be able to say, that's a pen. Another thing you can use is your watch. Can you tell me what this is? And if she can't get any words out, that is indicative of Broca's aphasia, which is that broken speech. Sometimes she might be able to get words out or the start of words, and it's almost like she's going to stutter. But that Broca's aphasia, it's almost like a locked-in syndrome. They know everything and they understand everything that's going around them, whereas the expressive aphasias may not understand everything that's going around them. So that Broca's, they're very frustrated, and sometimes you'll see them being very frustrated because they want to tell you something. They want to tell you about a symptom or when this started, and they can't get those words out. And then lastly is time. Again, asking questions to find out. They'll probably tell you if they have a thunderclap headache. And for our public, this is about calling 911. And that's it for our BFAST. Thanks, Joni. Thanks, Melissa. All right, so as we had talked about in our BFAST, left dominant hemisphere is most common on 95% of our population. And so when they have a left-sided stroke, they'll have the right visual deficits, either the expressive or receptive aphasia, and if they're really unlucky, they'll get global aphasia. And when we have global aphasia, it's very difficult to do a good assessment on them because they don't understand what's going on. They can't get words out. And that's a big cortical sign. And we usually see those a lot with large vessel occlusions. They'll have the left gaze preference. Remember that where the insult is, where the infarct is in the left hemisphere. So it's looking at where the problem is. And then they'll have the right hemiparesis, which could be that weakness, or they could be completely flaccid and paralyzed on that side, and the right-sided hemisensory. Now, putting it all together, this is what we do when they get to the hospital. We do a scoring tool called the NIH, and then we marry it with the FAST-ED scale here at Penrose St. Francis. And all of the Centura facilities use the BFAST, or the FAST-ED for their large vessel occlusion scale. Recognition basically is what I'm trying to say. It goes into our NIH tool. You can see there's like 11 pieces of information of neurologic problems that we're going through. That's why we don't want EMS providers doing this. It takes a long time to get it done. BFAST is much faster and it gives us all this information. And it also gives us information on this FAST-ED scale. So as you can see, facial palsy, you're going to get points for. Arm weakness, you're going to get points for. Speech changes, eye deviation, and neglect or denial. That denial, no, that's not my arm. The more points that you have, the more indicative that this is a large vessel occlusion. We say that a FAST-ED score of 4 or greater is an LVO. All right, so now we have a case presentation, and Melissa and I are going to do this together. So this was a patient that got both TPA and thrombectomy. So again, with your BFAST tool, you've got a 60-year-old man who was driving home from work, and he stopped by the liquor store, and he was drooling, and he had some problems with his left face and left leg weakness. And it started at 16:15, and he has a history of atrial fibrillation, which is that irregular heartbeat that some people can go in and out of. It's very, atrial fib people are hugely high risk for having a stroke, especially when they are not on anticoagulant therapy. This person didn't want to take his anticoagulants. So when the patient gets to the hospital, EMS reports that he was found with that left facial droop, left arm, and left leg weakness. So we've just done our face and our arms and our legs from our BFAST, along with speech. If he had any problems, well, he was drooling. That's significant, even at speech level. And so the BFAST, slurred speech, left facial droop, left arm weakness, and decreased grip is what they noticed. And this is what they reported, and they called a stroke alert in advance. This was a right non-dominant hemisphere stroke. So right gaze deviation, remember they would be pointing to where the problem is. The left neglect, the left visual problems, the left hemiparesis, hemisensory problems. Left-sided are usually going to show this way. So again, they did the stroke alert. They arrived at 17:02. They did an NIH. They got a 5. You can see where the points are on the NIH. He obviously was very positive in the BFAST evaluation. He got a CT of his head. He had a right middle cerebral artery occlusion. His CT perfusion showed a small area of infarct and a large area of penumbra. Remember, penumbra is that ischemic tissue. We can save that. And they called that into the ED doc at 17:40. At 17:38, they were already giving TPA. That was just 36 minutes after that patient arrived. And look, at 18:15, less than an hour of being there, they're already at the groin puncture, getting a thrombectomy with the interventional doctor to alleviate that large vessel occlusion. And he was able to do that. And a TK3 is a score that we give that tells us that they were able to open that occlusion completely. So why do we give TPA to large vessel occlusions? It won't clear the occlusion completely. The safe doses of TPA, those big, large occlusions that are close in that MCA circulation, it just can't do it, but it can create some collateral perfusion until we can go in and do the thrombectomy, and it can soften the vessel, which makes it easier to pluck that clot out for the interventionalist. So this was the CT perfusion that Melissa had gone over. And remember that red is dead, or the fuchsia side means that that's the infarcted tissue. And the green is the penumbra, it's the salvageable tissue. Our mismatch is fantastic here. So this is a person that we want to go in and save. And they did, and they were successful. So this gives you an idea of what it is. These are the pictures that are done when we're doing the thrombectomy. And when you look at this one over to the left, you can see that there's just, we're missing some circulation. And then as we're opening this up, we can start to see we're getting more circulation to this area, and then even increased better circulation to that hemisphere. So that, again, that TK3 score just means that they were able to open that up. And this gives you some of the other views that show you before and after. We definitely don't want this. This will mean you're going to a skilled nursing facility. This means you might be able to go back to the same quality of life that you had before your stroke. This patient, this is his MRI. So this shows his area of where his infarct is. Remember, it's opposite sides, and he had a right middle cerebral artery occlusion. He went home 2 days later. He agreed to take his Eliquis for his atrial fibrillation. His NIH stroke scale was 0. 0 is as good as you can get. So this means that this individual gets to go back to the same quality of life that they had before. They have no deficits left from having the stroke. Now we counsel them because his biggest risks are tobacco, that he smokes cigarettes, and excessive alcohol consumption. Both of those are going to increase your risk of both ischemic stroke and hemorrhagic stroke.
And just stay right there for a second. This is his MRI. And if you think about what we just saw on the CTP, really the area that was dead on that CTP is the area in the MRI that was dead. So all that green tissue that we saw in CTP was salvaged in that IR case. So
Which was
getting the
here.
clot out.
And here was where that green tissue was. If you look,
Yeah, there you go.
there we go.
So these are very advanced imaging, and I mean, it does give you a lot of information. So
It's not always this accurate,
no,
just so you know, but it's the best of what we have to offer at this time, and it's far more advanced than where we came from. So how can EMS help? Advanced notification for stroke alerts. Remember, I told you we were going to hit on this several times. Your pre-notification gets things ready and people ready to go because time is brain. And follow your key information to report and document. Remember your BFAST and write that down, and that's what you report for your neurologic deficits when you get to the hospital.
and I don't know if we hit on that earlier, but for BFAST, if you only have one of those things for balance, and it's dizziness and their balance, is still a positive BFAST. You don't need 3 or 4 of them to make
Right.
it positive. You get one of them, just call it.
That's a great point, Melissa, because not everybody is going to have multiple symptoms or signs. They may only have one. And they may be at the very early part of their stroke, and your BFAST assessment may change even en route to the hospital. So keep that in mind. The things that are time-saving that you do for us every day, check a glucose level. And if you treat them because they're hypoglycemic and they still look like a stroke, they are a stroke. And continue to check their glucose level because maybe they took too much of their medication and they don't know it, or too much insulin and they don't know it. So patient history is so important. Obtaining a family or significant other phone number and bringing that to you to the hospital and giving that to the nurse and the physician is paramount. We can't tell you how great that is. Bring a medication list, but what we say is best practice is bag up their medications and bring it to the hospital. Only provide oxygen if they're hypoxic. Follow your guidelines. Your physician advisor will tell you what you should be treating as a hypoxic patient. But remember, the two most important things for the brain is oxygen and glucose. Start IVs if you're IV certified. Remember, time is brain. Call ahead, call ahead, call ahead. Bother us. We love it. So the importance of bringing these patient medication, why is this? We think this is so important because sometimes they can have multiple different prescribing doctors, and not even their primary care has their true current medication list. Hospital records are only as good as your last visit. Your medications could have changed since your last visit, and it may not contain your current meds. It can help in the decision to giving thrombolytic medication earlier by having these meds at hand. So you play a very powerful role. We thank you so much for serving your communities, and we thank you for your time in joining us today. Melissa and I have loved talking with you. Here are your presenters. You'll have this information, and if you have any questions, please feel free to reach out to either Melissa or myself. We'd love to hear from you, and we'd love to have suggestions.
And email, phone numbers are on there. If you have questions from the presentation, reach out to us, or if you need more information or other resources, we can help you get those. And that's the biggest thing, because you don't need to know it all. You just need to know where your resources are to get information. And I think that's the biggest key takeaway from a lot of this.
And we'd like to thank Penrose St. Francis EMS Institute and Joni Briola for helping us put this presentation together today. Thank you so much.